So, kia ora koutou. I'm sorry I'm not able to be with you in person today. Thank you for this opportunity to describe our early work on a mental health project for young people set in primary care. The project is called PIKI, and we feel it's got significant innovations in both service delivery and evaluation methodology. As will be abundantly clear already today, there are good reasons for mental health being in the spotlight. At a global level, 1 in 4 of us has significant mental distress or problems at any point in time. And in New Zealand, as elsewhere, there's a worrying increase in mental health problems among children and young people. As a result of this concern, the government and the Ministry of Health were keen to provide additional psychological therapy support to young people along the lines of a large initiative in the UK called Improving Access to Psychological Therapies, or IAPT. So a request for proposals from the Ministry called for a pilot project which would support young adults aged between the age of 18 to 25, providing services for an additional 4,000 people a year with those suffering from mild to moderate mental distress. There should be a focus on equity, a positive approach on self-management skills, and an integration with other services and an evaluation of the project at the same time. So the RFP was awarded to the University of Otago and a local primary health organisation called Tuora Campus Health. Our project was named PIKI, which means to aid and support, but also to climb or ascend. Our project had a number of innovations. There was to be a very significant focus on co-design in both the service delivery and the evaluation with service users and young people. There would be opportunity for young people to get mental health and emotional support from other young people like themselves who had had experience of service use. We would also develop a digital platform to create online peer community support tools and other digital supports. And we designed also integration with other existing services such as the National Helpline 1737. And we also had the design strategically targeted at specific priority groups. The evaluation methodology was co-designed between service users and other academics, and the university team encompasses a wide range of research skills and disciplines. So the sequencing of the evaluation and our mission to boldly go is in line with Donna Bedian's assessment of quality in healthcare, structure, process and outcome. So in the first phase, we've been exploring how the project and the pilot would be set up, how transition would occur from existing services. This is achieved by a great deal of participant observation, document review and interviews with key stakeholders. We've begun to look in detail at the processes that sustain or challenge the project. For example, how well our target population is being served. And although we've started to collect some outcome data, most of that won't be available for some time yet. We're aware of the complexity of the project involving multiple partners and the delivery of different service elements, and have developed an analytic framework which combines aspects of complexity science, implementation science and appreciative inquiry. Why is it necessary to do this? Because although health services seem to think they are planned in a linear and straightforward way, like very much else in life, they're far from it. This picture shows a flock of starlings weaving and diving in a pattern which starling scientists call murmuration. No one knows why they do it. PIKI also shows elements of complexity. The diagram on the right outlines the different elements of the project as we designed them. On the left is a partial representation of the different ways in which we now see a service user trying to navigate the options that we designed. Analysis of such projects is both fun and daunting. And here's an outline of our overall evaluation framework. So complexity science explores such things as unexpected emergent events, self-organisation, and the need to look at the performance of whole systems from a non-linear perspective. We're also interested in the way that, having developed services within a complex environment, implementation can take place according to best practice and evidence principles. We have, as our evaluation core value, the concept of appreciative inquiry. This is based on the premise that people want to make things work well and do a good job, and that by taking a positive and strength-based approach, then evaluation can uncover and disseminate incremental innovations which are useful both for this particular project, but also if and when initiatives become scaled up. We've been using a mixed methods approach, collecting both quantitative and qualitative data. From a numbers point of view, we want to focus on both service providers, what they do and how they do it, but also find out what happens to the service users. We feel that stories are equally important as numbers, and we're using a wide range of qualitative methods to provide the detailed context and narrative from many different perspectives. Both the quantitative and qualitative data sets have challenges in terms of addressing co-design principles. So each element of the evaluation framework, and particularly the qualitative interview schedules, is not only discussed by the academic team, which contains service user academics, but is also being co-created with members of both the service and youth reference groups. It's now 8 months into the start of the project. What's happening? Well, overall there are indications of early success, not least in the fact that many young people have already been helped by these new services. How is success measured? Well, everyone knows that on the internet and in PowerPoints the most important marker of success is a fluffy kitten. And so for this project so far, the project has a 7 out of 10 fluffy kitten rating. High praise indeed. How was that achieved? Importantly, for a project with such diverse elements and starting points, there's been a successful transition from existing platforms of work. So each of the provider services already had mental health services, which were directed to some extent at young people. That transition meant recruiting and training new staff and retraining existing staff in new ways of working. Infrastructure was required to do that, but also to create the digital platform and the incorporation of peer-to-peer networks. In addition, the evaluation has worked in tandem with service delivery, both collecting data but also feeding back observations such that course correction to service delivery can be made. And most importantly, as stated before, young people have already been helped. The response to the service has been enthusiastic, and target numbers of both clients and therapy sessions have been achieved. There's been activation of the digital app platform and access through the website. So all aspects of the project have been activated successfully. Though it's early days, we've already identified a number of important questions and in some instances ameliorated a number of challenges. Here are some of them. The first challenge encountered is a philosophical one. How is the project framed and what's the underlying ethos? Well, from the outset there was a debate about the contrast between a medical model, which is based on mild to moderate mental health problems and disorder, versus a focus on providing positive support to people from an enhanced resilience and mental wellness perspective. So taking an appreciative inquiry approach, this led us to recognise the negative connotations of solely taking a diagnostic illness framing, but this was also balanced by the need for a medical model at times to assess severity. The initial UK model was developed within a traditional model of cognitive behavioural therapy delivery. We've had robust discussions about how fit for purpose that might be for the New Zealand context, and as a result, quite significant changes were made within the first few months of the project. We now have a CBT framed therapy approach, but with some variations in both style and content according to local context. There were challenges in integrating and interfacing PIKI with both existing and new other enhanced services and workforce in the mental health field locally. In this environment, it's important that the evaluation was able to provide clarity about who was providing what and why. The Ministry initially funded us for a 3-year project, but even before the contract was signed, asked if we could deliver that 3-year project within a 2-year time frame, but with 3-year volume outcomes and funding. The compressed time frame has had significant impact on workforce, both recruitment and training, and also on the ability of the project to deliver authentic co-design principles. So one of the most significant ways that PIKI was designed to do things differently was by using a co-design model and fully engaging with both service users and young people. The compressed time frame of the project has significantly called into question whether the project is serious about co-design or whether what is being delivered is more in keeping with a degree of co-production or merely collaboration with service users. There have been a number of operations and implementation issues. PIKI clients have multiple ways in which they can access services: digital, peer support, referral from their GP and so on. And it took several months before the implications of this were absorbed into an effective method of intake coordination. Because of demand, expectations were revised as to what would be considered reasonable from a service delivery point of view. Initially, it was planned that clients would be seen within 3 working days, but at one point the waiting time to be seen was 4 weeks. clearly undesirable when it was becoming clear that for many of the young people there was more significant levels of distress than had been anticipated. There was also debate as to how clinical risk can be safely managed in the context of a service designed to mainly address mild to moderate distress, and also from an evaluation perspective, what measures are appropriate to measure distress. At one point there was a vigorous discussion led by young people themselves, resisting the idea of any assessment of clinical severity. Yet it was vital from an evaluation perspective as well as from a clinical safety perspective that we had an idea of outcome measures as well as intake and interim assessments from that clinical safety perspective. PIKI's got a complex governance structure. There are multiple steering and advisory groups with overlapping membership, terms of reference and roles, which led to challenges in effective decision making. At the time of this presentation, all areas of PIKI are operating at full capacity for face-to-face therapy, and there's an increasing use of online access and telehealth contacts. More young people are taking up peer-to-peer support services, but as yet there's been no direct public marketing and publicity. And the great majority of clients, particularly in the Wellington area, are tertiary students. So we should ask and assess then how well the needs of the target groups and priority groups are being met. The initial launch in Porirua made a specific focus on Māori support and approaches, but some of the momentum for that has been lost, particularly due to the heavy demand from tertiary student populations. While 16.5% access of the service by Māori to PIKI might be in line with population demographics, we know that there is an increased need for services for Māori, and therefore PIKI is underservicing. It's also clear that PIKI as yet is not achieving appropriate Pacific response or access. There's also been concern expressed from other groups such as the Rainbow community that there's not sufficient attention paid to diversity needs. So these issues and others illustrate from an evaluation perspective the value of our complexity implementation lens and our ability to provide continuous feedback to the project teams. Complexity science encourages us to acknowledge unpredictability, expect it, and develop a flexible response. This was evident in an unpredictable event where the promotion of a local launch helped raise expectations as to capacity, leading to unexpected demands on the service. We were able to alert the project to the predictably unpredictable unexpected event and its impact and support appropriate mitigating measures. We've encouraged the design of both project and evaluation to be tailored to local contexts. Lower Hutt is not Wellington, is not Porirua. And complexity and implementation science recommends that we listen repeatedly to local voices guiding us to make course corrections locally when required. We're currently, for example, exploring why, despite heavy interest in initial demand, there are high rates of non-attendance for some service settings. We're trying to conceptualise surprises as opportunities, not just in service delivery, but in the evaluation as well. Faced with a degree of resistance from the youth reference group to outcome measurement, we took the opportunity to attend their reference group meetings to gain more information about their concerns, but also to collect narrative data for the evaluation. There's been ample evidence of us collectively learning and adapting during the intervention, and on a number of occasions a recognition that what's in place now may well be modified either in time or in another place. There have been instances where new partnerships and people have been introduced to the project and where productive relationships have developed as a result. It's early days in the evaluation, and already we probably have enough data for several research lifetimes. Our brief will be to deliver results quickly, however, because PIKI is a pilot project in an exciting but somewhat frenetic mental health project and initiative landscape. The government commitment to mental health is very welcome, and it's important that initiatives with potentially significant implications for both workforce and healthcare outcomes are robustly evaluated.